Hello everyone, my name is Ntuli Kapologwe. I'm the Director General of East Central Southern Africa Health Community. I'm very much delighted to be a keynote speaker at this very important symposium on family medicine under the title From Episodic to Longitudinal Care, Advancing Universal Coverage through the 5 C's of Primary Health Care. First and foremost, let me thank Professor Rugajo and the entire organizing committee of this symposium for having invited me to present on primary health care. Let me begin by talking a little bit about East Central and Southern Africa Health Community, or ECSA Health Community. This is an intergovernmental and Pan-African health organization that fosters and promotes regional cooperation in health among member states. It was established in 1974, and formerly it was known as the Commonwealth Regional Health Community Secretariat for East Central and Southern Africa Health Community. Our main focus is strengthening primary health care and family health across all the member states. Currently, we have 9 member states, namely Eswatini, Kenya, Lesotho, Malawi, Mauritius, Uganda, Tanzania, Zambia, and Zimbabwe. However, our work spans up to 30 African countries, as you can see from those countries that are painted yellow. Those blue ones, these are the ECSA member states. As our core businesses, we have 4 main core businesses. One, technical. We offer technical support to the member states. Secondly, we offer research and innovation support to the member states. Third, we do conduct consultancies. Last but not least, we do offer training, both short-term and long-term training to the member states. And as per training, we have a total of 11 College of Health Sciences that operates under the umbrella College of Health Sciences. One of the colleges is ECSA College of Family Physicians. So let me now invite you to the talk that I've been assigned to give today. That is primary health care in Tanzania, looking into lessons and opportunities for family medicine. I'll take you through a number of terms or definitions that need to be understood before you get to understand the context of my presentation. The primary health care is essential health care based on the practical, scientifically sound, and socially acceptable method and technology made universally accessible to individuals and families in the community through their full participation at the cost that the community and the country can afford. Primary health care simply means a whole of the society approach to effectively organize and strengthen national health system to bring services to the health and well-being closer to the communities. It is centered around people, needs and respects their preferences. It is most inclusive, equitable, and cost-effective way to achieve universal coverage. It is key to strengthening resilience of health systems to prepare for, respond, and recover from shocks and crises. Looking into another terminology as far as my keynote speech is concerned, is universal coverage, which means that all people have access to the full range of quality health services they need when and where they need them without financial hardship. Whereas longitudinal care means knowing the patient beyond the diagnosis, understanding the family, the social and environment context, managing risk before disease occurs, coordinating care across levels and over time. Mind you, the thin line between primary health care and family medicine. While primary health care is a vehicle for longitudinal care, family medicine is an engine. Family medicine is uniquely positioned to shift health system from episodic to longitudinal care that accompanies individuals, families, and communities across the life course. Looking into episodic care, across many resource-limited settings, health system care remains episodic. Patients enter the system when they are sick, they see different providers, records are incomplete or sometimes absent, prevention is usually secondary, and follow-up is uncertain. As a result, there's a late presentation of disease, poor control of chronic conditions, inefficient use of limited resources. Episodic care treats illnesses, but it does not build health or systems. Universal health coverage is not simply about coverage. It is about continuity, accessibility, affordability, quality, and outcomes over a lifetime. And primary health care is the backbone of universal health coverage, and therefore prioritizing it is not a cost, rather it's an investment to address episodic care and achievement of health for all goal. Why focusing on primary health care is both strategic and timely? Primary health care is a bedrock of health system. Evolution of global health architecture right now is calling for strong primary health care, reduced donor funding, tighter country fiscal space, that's shifting from the burden of external aid towards sustainable locally financed system, but cost-effective interventions. Most of the interventions that have proven to be cost-effective at the primary health care level. Now there's emerging new tools, technologies, products, and innovative delivery approaches that calls for primary health care. Universal health care agenda, the role of primary health care is there because primary health care is a bedrock and it's also the backbone of the healthcare system. So with the universal health coverage index of 46 for Africa, whereas the globe of 68, for us to be able to catch up, we need primary health care. The last but not least, to sustain the narrative of prevention is better than cure, instead of twisting it the other way around. This slide, I'm going to take you through the couple of milestones of global policies and strategies that have been achieved so that to come up with comprehensive and robust primary health care. From 1978, when we had Alma Ata declaration with the health for all by year 2000, to the year 2000, when we had the UN Millennium Development Goals, MDGs, up to the year 2018, 40 years after Alma Ata, when we had the Astana Declaration. These are some of the milestones that are very important for the movement or achieving the primary healthcare services that we want. Now, there are a number of existing regional and global policies and strategies that support primary healthcare agenda. Recently, in the year 2023, we had the SAC agenda, which points into the importance of primary healthcare as the backbone of healthcare system. Then last year, we had the Africa's Health Sovereignty Agenda, which is a package, it's a bundle from the use of digital technology to the local manufacturing to strengthening primary health care and health security. Then we had the Abuja Declaration of the year 2001. And without forgetting, last year also we had the pandemic agreement being signed alongside with a revision of International Health Regulation of 2005. Now, looking into the primary healthcare principles as per Alma-Ata 1978, there were 5 principles. One is equity to access, acceptability, and affordability. And then you realize that with that principle, this is what we call nowadays universal coverage. The second one is community participation, involvement, and engagement. Primary health care is about community. It's about a group of people. Whereas the third one is intersectoral collaboration, having nutrition being part of the primary health care equation, water, hygiene, sanitation, as well as education, as health belongs to all sectors. Therefore, we need also to include issues to do with climate change, economy, One Health, and to name few. The fourth principle is on prevention, to ensure there's maximum productivity from surveillance to early disease detection, then moving to disease intelligence is parcel of primary health care principles. The last but not least is appropriate technology to ensure cost effectiveness. Nowadays, people are talking about artificial intelligence, AI, but this is something which was mentioned in 1978. So there's nothing new, it's just implementation of those principles of primary health care. Now, looking into the relationship of the terms which I have defined previously from the previous slides, the family care, the primary health care, and universal coverage. So you find primary health care and family care, these are simply approaches, whereas health systems are the means, and the universal coverage and sustainable development goals, these are the goals to be achieved. But again, I would like to remind you that family care is an engine of longitudinal care, whereas primary care is the vehicle of longitudinal care. Now, looking into how Tanzania is faring in terms of universal coverage index, Sub-Saharan Africa is having the universal coverage index of 46, whereas that of Tanzania is 43. But the global universal coverage index is 68. So if you compare Tanzania to the rest of the ECSA region countries, is the one with the lower universal health coverage. And this one means that we need to put more investment into the primary health care if we are to raise the universal health coverage. Now, how the Tanzanian health system is organized. So, healthcare system in Tanzania is highly decentralized. The Ministry of Health is responsible with policy formulation, standards, setting up standards, resource mobilization, and overseeing secondary and tertiary level healthcare services. While the Prime Minister's Office, Regional Administration, Local Government is mandated with implementation of the policies that have been formulated by Minister of Health, but also implementation of primary health care. So primary health care is one of the components. Looking into the diagram to your right-hand side, you can see that our healthcare system assumes the pyramid shape. At the base of the pyramid, we have the communities, then followed by dispensary, health centers, and the hospitals. And these are the ones which constitute what we call the primary health care. And this is a gateway or the first counter to more than 95% of Tanzanians who visits our healthcare systems. Now, looking into the healthcare system, primary healthcare is not just an approach, but it's also a comprehensive health system with all the building blocks. So it was 2 years ago, we took a look into the 6 WHO's building blocks, and we found that they had some still gap to be able to capture some of the very important determinants of health. So under the book which we wrote, Primary Healthcare in Tanzania Through a Health System Lens, a history of the struggle for universal coverage, we were able to identify 4 determinants of health that needs to be working alongside with the 6 building blocks. And that is political determinants, socio-economic determinants, global health initiative determinants, and commercial determinants. We need all these determinants to be working close with all 6 building blocks for the primary healthcare to thrive and to respond to the people's needs. But now there's a puzzle where primary healthcare ideology came from. Who were the pioneers? So majority of Tanzanians who worked as public health specialists, historians, scholars, especially those who lived in 1960s and 1970s, believes that primary health care was born in Tanzania, especially in 1967 when we had the Arusha Declaration. And it was declared in 1978 and revived in 2018. And in the next slides, I'll get to explain this, where did they get this narration, all this actually evidence that primary health care was born in Tanzania. So this is the evolution of primary health care in Tanzania. It's dated in 1891 when we were under the German rule. The Germans established the department that was looking for health. In 1961 is when Tanzania gained independence, but one of the very, very important activities that was done after gaining independence was 1962, when the founding father of the nation, Mwalimu Julius Kambarage Nyerere, actually conducted a review of health services in Tanganyika. In 1967 is when we had the Arusha Declaration, and many scholars and historians believe Arusha Declaration is one of the very important input as far as the Alma Ata Declaration of 1978, because number of the principles of primary health care were obtained from this Arusha Declaration, the health for all and the other thing. 1982, we had the establishment of the Local Government Act and the department. 83, the primary health care department was established within the Ministry of Health in Tanzania. Then we fast forward going to 1994, we had the health sector reform, and most of the reforms were on how do we make primary health care strong and responsible to the people's need. So up to the year 1995-96, when the primary health care was embedded into the President's Office of Regional Administration and Local Government, is when the department was also established to be able to oversee the implementation of primary health care activities in the regions and districts or councils across the country. So this is a bit of the evolution of primary health care in Tanzania from 1800 to the year 2022. Looking into some of the reforms which were associated with the evolution of primary health care is after independence, the services has been provided free of charge to all Tanzanians, followed by 1993 when we had the structural adjustment program, and it was during this time when there was introduction of the user fees. Then 94, as I said, we had the health sector reform when we started to have the cost sharing policy, then followed by the community health fund pilot in one of the districts in Tanzania, the Igunga district in 1996, then followed by the National Health Insurance Fund, then up to 2024, when we had the launch of integrated and coordinated community healthcare program. So this, in short, this is the reforms around healthcare financing, especially at the primary healthcare level. Looking into the reform, there's one notable reform which we must mention. That is the introduction of direct health fertility financing in the year 2017, when the government of Tanzania decided to start dispersing funds direct to the primary healthcare facilities. And one of the things that actually came up with that type of reform, implementation of that reform, is empowerment of the lower facilities to be able to actually make decisions, but also it resulted into improvement of quality of services, especially primary healthcare services at the community level. Now, looking into some of the primary healthcare campaigns that have been successful since 1961, when Mwalimu Nyerere actually declared 3 enemies. One is illiteracy, second poverty, and third was diseases. And Mwalimu Nyerere, the founding father of Tanzania, actually in 1967 is the one who championed the Arusha Declaration. And looking into the Arusha Declaration and the Astana Declaration, you can clearly see all these 2 declarations, they were speaking to actually having health for all. And in so doing, we see all these enemies which were mentioned by the founding father, Mwalimu Nyerere, were addressed through this Arusha Declaration. And why now the scholars and also historians and authors like me do believe that the idea of primary health care came from Tanzania? It was during that particular time, I think 1973, that's 5 years before the Astana Alma Ata Declaration, the Director General of WHO visited Tanzania, and they was able to have some engagement with people at the ministry, 1973. And 5 years later, then we had the Alma Ata Declaration. So primary health care, to a great extent, came from Tanzania. So then the other campaigns that we had during that year, it was the Ntuli campaign, which was trying to improve the way people are living by making an emphasis on the hygiene and sanitation, physical activity, health eating, which I believe, again, if people were able to carry and continue with this campaign, today we would have had very few people with non-communicable diseases. This campaign has been revised in the year 2023 as Ntuli campaign second term. So we want also to make sure that people promote this campaign so that we can have the healthy society. The other campaign, it was on the toilet construction as part of Ntuli campaign. Usichukulie poa nyumba ni choo. This has been one of the campaigns which has actually transformed the way communities have viewed the issue of hygiene and sanitation. And it's working still very well. And my call and my plea to colleagues at the ministry is to continue pushing for this one, because this is purely the primary healthcare campaign, which is transformational. Now, apart from this other campaign, we have had also very successful vaccine campaign. In the year 1975, we had only 3 vaccine antigens, but in the year 2023, we had 10 vaccines against 14 diseases. So this is one of very successful expansion of vaccine services as part of the prevention. So now that brings me to another slide, which I'll be talking on the primary care. But before proceeding, I think there's the importance of knowing what is primary care, because people are using the 2 terminologies, primary care and primary health care, interchangeably. but there's a very thin line between these two words. While primary care describes a narrower concept of family doctor type, that is family medicine physician, services delivered to individuals, and the key word there is individual approach, primary health care. This is a broader term which derives from the core principles articulated by WHO in 1978 and which describes now approach of health policy and service provision that includes both services delivered to individuals, the primary care services, and population level. So, in other words, is that primary care is a subset of primary health care because individuals' health as well as population level public health both are included into primary health care. Now, there are 5 C's of primary care. As you know that primary care is the first point of contact people have with the healthcare system. The 5 C's include the first contact, the continuity, the comprehensiveness, coordination, and also contextuality. The first contact, this is accessible entry point to the healthcare system. And with this first contact, it usually reduces unnecessary referrals, but it improves equity. And primary care always must be the first point of entry into the healthcare system. And when primary care is accessible, trusted, and well-resourced, patients always seek care early, conditions are detected sooner, costs are lower for both households and the system, and without a first contact care, universal coverage remains aspirational. Then on the continuity of care, that's a care over time, and a trust and therapeutic relationship, when there is a better outcomes and satisfaction at this a particular level or this C. But also it enhances now the adherence or compliance to medication that is provided to the patient or the clients. Then on comprehensiveness, with this type of C or this C, all ages and conditions need to receive a comprehensive care, preventive, promotive, curative, rehabilitative, and palliative care. And the family medicine at this level, it usually tends to address of prevention and promotion, acute and chronic conditions, mental, physical, and social health, and the comprehensiveness ensures that primary care responds to real needs, not in a fragmented way. Whereas in coordination, this is just linking the community, primary and referral levels, effective referrals and follow-up, and the family physician at this particular level, they are navigators of the healthcare system, the integrators of referrals, diagnostics, as well as specialist care. So without coordination, expansion of services leads to inefficiencies, not equity. On contextuality, which is the last series of primary care, the care is tailored to a family, a culture, and community. It addresses social determinants of health. But at this level is when now we are seeing another evolution of primary care. The issues to do with wellness programs, yoga, and others are captured at this level. But all in all, what I can say, the primary care is well embedded into the primary health care, as primary care focuses mainly on individuals vis-a-vis primary health care, which is combination of individuals and their population-based health care. Now, there are a number of achievements that primary health care has actually witnessed in Tanzania. One is the expansion of health facilities. Now it records at 80% of the people residing within 5 kilometers of those facilities. And also in Tanzania, they had the launch and inauguration of the community healthcare workers program. And there's a police commitment to universal coverage through universal insurance. Now, recently, the government launched the universal insurance agenda so that no one is left behind, and there's no single Tanzanian who cannot access healthcare due to financial constraint. Reductions of mortalities. Now we have seen reduction of maternal mortalities from 556 to 104 per 1,000 live births. And that is not just numbers. This is a massive achievement. But the other thing is establishment of department within the Prime Minister's office in the year 2015, 2016. And then also decentralization of diagnostic services. Now we have X-ray, ultrasound, as well as some other diagnostics at the primary healthcare level, which is a huge achievement. This is just to show you one of the photos of the primary healthcare facility, which really demonstrate that the government has invested heavily, and what is needed now is the delivery of services up to the standard. The other one, this one, you find this is an OPD building. We have a mortuary building, X-ray building, and other maternity complex, which really are there to offer the primary health care as a facility level. This is just to show you a line graph on the infrastructure growth in Tanzania. You can see there's a sharp rise in terms of construction of primary healthcare facilities, and that is very important in terms of reducing the distance of the people traveling to the healthcare facilities. Looking into the public health infrastructure growth again, you find with that one, it has resulted in revised trend in child mortalities, as you can see from this graph. From this graph, you can clearly see that there were a number of scenarios, but even before 2015, already the child mortality rate went down, and this is down to Imam Mpangwa Maendeleo Afya Msingi or Primary Healthcare Development Program, which actually brought primary healthcare facilities close to the people, and hence reduction in mortalities due to the service availability. And this is to show you a reduction also of maternal mortalities and the achievement of child mortality and the achievement of Millennium Development Goal 4 in the year 2010. It was also achieved very early due to massive investment that was done between the year 2005 to 2010. And as I said, in January 2024, the government of Tanzania launched the coordinated and integrated community health program, while they were envisaging to have 137,284 community health care workers deployed in all the villages and hamlets across the country. And that is one of the very important primary health care components as well. Looking into the under 5 mortalities, you can see most of the indicators from under 5 to neonatal to the infant, they are experiencing downward trend, except for neonatal mortality. It's not that sharp. I think there's more investment that is needed, particularly at the primary healthcare level, so that to make sure that we achieve the set goals, especially sustainable development goals before or by 2030. On maternal mortalities, yes, there's massive decrease in maternal mortality ratio by 80%, from 556 to 104. That's massive. And this is one of the indicators that is very promising going forward. And looking now into financing, still there is some work to be done, as recently there was a launch of universal insurance, but still we need to invest on how we harness domestic resources, also coming up with innovative financing and the blended financing. All these are highly needed for a country like Tanzania to be able to self-sustain in its delivery of healthcare services. On the challenges that we have, still there's a shortage of human resource for health, a fragmentation of care in some of the areas due to the vertical programs. So this is one of the areas that need to be really looked at. The financing gap and the stunting of children, which still stand at 30%, but also lack of primary health care desk at the Ministry of Health. That is also one of the huge challenges. Looking into actual capital expenditure for primary health care, there's a variation across regions in Tanzania. And all of the regions, and include the Tanzania as a country, is below the WHO recommendations. So here, there's a need to increase more financing to primary health care so that it can deliver services as per actual expectations. And healthcare workers availability, there's a variations again across the country. Dar es Salaam, there are so many primary healthcare workers, followed by Kilimanjaro, Dodoma, then we have Iringa, but we have some other regions with high population, like Geita, needs more healthcare workers at a primary healthcare level, Simiyu. And if you look at these regions at the right-hand side, these are the regions with high population density. So we need to have strategic allocation of healthcare workers if we are to improve primary healthcare delivery. Looking into the budgets allocations as per Abuja Declaration, again, Tanzania is somewhere below, but with universal health insurance, we believe it will help to have more resources for primary health care. So maybe the picture might change towards the end of this year or the year after, so due to the universal health insurance. And I also looked at the enrollment for ICHF. There has been actually a trend which is varying time to time, but overall we need to have more investment. As the good thing, this is embedded into universal insurance, so that shouldn't be the challenge at all. Now, across the ECSA region, human resource for health, you see countries, how are they faring? Tanzania, again, is somewhere between Uganda and Lesotho. So we need more staff. Mauritius is performing very well, as well as Eswatini. Looking into nutrition indicators, primary health care cannot be separated from nutrition. Stunting, underweight, wasting, overweight, and anemia remains to be the challenge for Tanzania. And this can be easily addressed at the community. You cannot address this one at the secondary care or at the tertiary care. So family care, primary health care are highly needed to be able to reverse the challenge of all the challenges of nutrition in the country. This is just to show the distribution of stunting burden and the population by the region. You can see the high basket regions are the ones who are suffering most. So it means here we need primary health care approach, family medicine, or primary care to be able to reverse this one. Why is it that the regions with high production of food are the ones which are suffering from the stunting? It means there's a lot of cultural issues, a lot of education issues that need to be directed towards those regions. Now, what are the opportunities? As I said earlier, ECSA has a College of Family Physicians. And today we are attending a symposium on family medicine. We use this one as one of the opportunities for regional professional body to strengthen family medicine, to standardize training, but it is cost effective because people are attending their masters while they are in their duty of station. And this one helps to build the workforce capacity. It supports primary healthcare reforms. You know, it's very difficult to separate between family physicians from the primary healthcare. You cannot separate them. But also it promotes regional learning. So these are important references, and I had privilege to be part of these two projects, and I edited both. One is on primary healthcare history in Tanzania. We have been able to document all these family medicines, family physicians, primary healthcare as well. And how did primary healthcare in Tanzania evolve? And what were the struggles to arrive where we are? And also on leadership and governance in primary care, taking some of the exemplars in the resource-limited setting. So I would strongly encourage people to read these books, and they are really available in Amazon. So you can order your copy online and get to actually read and understand the primary care, primary health care, family medicines, and what are the actually leakages and relationship exist between these different disciplines. So in conclusion, family medicine is central and an engine to longitudinal care. And longitudinal care is essential for universal coverage. And while the 5 C's guide strong primary health care and part of primary care as well. Above all, primary health care is the backbone of universal coverage. Therefore, we need to be very strategic. We should invest both on primary care and primary health care, but knowing that primary care is a subset of primary health care. Thank you very much for your kind attention.